Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is an introduction to our next episodes, which are going to be covering the topic of vasculitis. So, what is vasculitis? This describes the inflammation of blood vessels, and any or all of these may be affected depending on the type of vasculitis which we are discussing. And as we will find out, there are a wide-ranging number of conditions which fall under this category. Largely, they are all characterised by the presence of constitutional symptoms, with specific signs and symptoms depending on the type and also depending on organ involvement. And as you might expect, the epidemiology does vary depending on the subtype. So, for example, some are diseases of childhood, such as Kawasaki disease, and some affect the people over the age of 60, such as giant cell arteritis. And we'll learn more about both of these as well as others in coming episodes. Vasculitis may arise due to many factors such as infections, malignancies, and can even be drug-induced. However, the ones that we will mainly be speaking about in the coming episodes and the ones that are most relevant for your MRCP examinations mainly fall into one of the following categories. So these are mechanisms of how vasculitis may arise. So firstly, may be due to immune complex deposition. And an example of this is polyarteritis nodosa, which is usually, in a lot of cases, secondary to hepatitis B. The second form may be direct endothelial cell infection, such as the case in HIV. The next form is anti-endothelial cell antibodies, such as is seen in Kawasaki disease and in Behçet's disease. And the next form is due to an antibody called ANCA, and so you get ANCA-mediated neutrophil activation, and this is seen in the ANCA-associated vasculitides, which we will do an episode on in the coming weeks, and T-cell dependent injury, and an example of this is giant cell arteritis. It's important to remember that the immune mechanisms of some vasculitides, particularly some of the rarer ones, does remain uncertain. This is quite a famous diagram from the Chapel Hill classification of vasculitis. So this sits within the classification criteria paper. The reference is given at the bottom there. And it just gives a nice schematic of where each of the vasculitides sits as per the vessels they mainly affect. So if we look on the extreme left-hand side, as you're viewing the screen, large vessels may be affected by conditions such as giant cell arteritis and Takayasu arteritis. We then have the medial vessel vasculitides, which include polyarteritis nodosa and Kawasaki disease. And then we have the ones that gradually affect the smaller arteries mainly, and these include the ANCA-associated small vessel vasculitides. So examples of this are microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis, and we'll do an episode on that. Some of the rarer ones, which we will also cover in some depth, will be cryoglomulonemic vasculitis. So this falls under the immune complex small vessel vasculitis. Henoch-Schönlein purpura, which is another vasculitis mainly of childhood or older teenagers, and also urticarial vasculitis, as well as anti-GBM disease, which is also known as good pastures. Other vasculitides are not mentioned on here, so these include Behçet syndrome, for example. And as we said before, because of the large heterogeneity amongst these conditions, there's no single typical presentation, but you should really be suspecting a vasculitis in anyone who is constitutionally unwell. So this includes symptoms such as fatigue, weight loss, fever, as well as musculoskeletal features such as arthritis, arthralgias, and myalgias. Organ-specific features, again, really depend on the type of vasculitis we're talking about. So some vasculitides do tend to affect predominantly the kidneys, the lungs, whereas others may have a predisposition for the main cardiovascular system. So some examples of how the different organ systems may be affected are given here. So just to pick out a few examples, we've got jaw claudication there under the category of cardiovascular, and that's something which you typically see in giant cell arteritis. Loss of vision, which is within the central nervous system heading, is also seen in giant cell arteritis. You may get glomerulonephritis, particularly with an ANCA-associated vasculitis. This can sometimes lead to fulminant kidney failure with an acute kidney injury. And similarly with the respiratory system, ANCA-associated vasculitides may also cause pulmonary hemorrhage. And something which may be seen in several of these conditions, particularly the small vessel vasculitides, are a purpuric rash or vasculitic lesions on the skin. So quite wide-ranging, and specific organ involvement will be discussed for each episode pertaining to that particular type of vasculitis. Investigations should be guided by the suspected form of vasculitis, but usually you would start by doing some bedside tests, including blood pressure, which can be quite pertinent for certain forms of these vasculitides, as well as a urine dip, looking for any kidney involvement. Then you would do a baseline set of blood tests. So this would include your usual full blood count, renal function, liver function, and bone profile, as well as crucially inflammatory markers, which do tend to go up in these conditions, so CRP and ESR. Antibodies, again, will be guided by whichever form of vasculitis you are suspecting, but the specific ones to be aware of are anti-neutrophil cytoplasmic antibodies, or ANCA, anti-glomerular basement membrane, or anti-GBM. And usually a connective tissue disease screen, as we've previously discussed, would be undertaken in these patients just to ensure there's no overlap symptoms or any other underlying cause of their symptoms. Again, imaging is guided by the type under investigation. So, for example, in giant cell arteritis, you might request an ultrasound scan of their temporal arteries, which are mainly affected in that condition, or you may require an MRA if you are suspecting a medium vessel vasculitis, for example. And finally, a kidney biopsy can be quite useful to clinch the diagnosis in these patients as well. So now a question which may come up in one of your MCQ exams. So which of these conditions is a small vessel vasculitis? So the options are Takayasu arteritis, giant cell arteritis, Kawasaki disease, granulomatosis with polyangiitis, and polyarteritis nodosa. So you will remember that from the Chapel Hill classification and the diagram which we discussed earlier, that granulomatosis with polyangiitis, out of those 5, is the one which is a small vessel vasculitis. So thank you for listening to this episode of Bite-Sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you'd like to hear from us in the future, and we'll see you in our next episode.